Building block 3, empanelment, continuous panel size management. Empanelment, the third building block in the 10 building blocks of high-performing primary care, is the process of linking each patient with a specific primary care clinician who serves as the regular source of care. At a practice level, empanelment also aims to understand who is at home in the medical home. In other words, empanelment allows us to identify which patients are attached to a practice, whether primary care or specialty, and see that practice as the regular place for obtaining care. In a solo provider practice, all patients are considered automatically empaneled to that provider. Both solo provider practices and multi-provider ones, however, can benefit from mastering the mechanics of empanelment, which allow a practice to identify its active patients, its patient panel size, and its capacity and demand. This information is crucial to supporting other transformation efforts. In this presentation, we'll see how we can operationalize the empanelment framework and keep our panels up to date and balanced once we have a defined patient panel in place. We'll also learn how to stratify our patient panel based on different levels of care needs in order to provide targeted population health strategies. Let's start by exploring how we can initiate a longitudinal approach to managing our panel and keeping it up to date. Maintaining accurate panels is vital to having accurate quality data and managing the needs of a population. Thus, empanelment does not end when the initial empanelment list is done. As clinicians turn over or change their clinical time, and as patients come into and leave the practice, someone needs to keep track of the changes. Often, this is the job of the practice manager in consultation with clinicians and clinic leadership. In a smaller practice, it may be the medical assistant. Having protocols in place for the front office can help keep panels clean. A front office clerk can ask, "I have your primary care clinician listed as Dr. Jones, is that correct?" and change assignments if appropriate. That same person can be empowered to note when a patient reports plans to move or change practices, so they can be marked as inactive patient in the EHR or registry. Panel scrubbing is the process of reviewing panels on a regular basis to ensure that they are accurate. Ideally, this occurs every 3 to 6 months. It can be as simple as running lists and having the care team scan those lists during a meeting to identify people who are incorrectly assigned or who have left the practice or passed away. Note that we are usually not asking clinicians to sit down and look up patients. Rather, we're asking them to point out cases that they think may require some looking into. If the practice does not have an electronic health record that classifies people as active based on the date of their last visit, the panel scrubbing process is also a moment to identify people who are no longer active. When determining who their active patients are, most practices choose a time frame ranging from 18 to 36 months and focus their outreach efforts and define their quality metrics based on specific considerations within this time frame. For example, a practice may consider the following questions when deciding which types of encounters qualify a patient as active. Are we only counting patients who have had at least one preventative care visit? What about patients who are participating in virtual encounters more frequently than in-person encounters? Are telephone calls eligible if, for example, a patient has had a prescription refilled in the past couple of years without actually having a face-to-face visit? Does a patient portal message count as an encounter for that matter. What do we do if a patient has never been seen in a practice but was assigned to a provider by a payer like managed Medicaid? Many practices have a shadow panel, a list of people who have been assigned to the practice by a payer but who have not engaged in care. Some practices conduct outreach to this shadow panel to establish care before an urgent issue arises. Proactive outreach to shadow panels may help to improve preventive and chronic care quality measures, which can have direct financial impact on practices if a portion of their income is through value-based payments. In addition, outreach calls can identify patients who have been misassigned to the practice. Front office staff have an important role to play in reconciling practice and health plan panels. Patients frequently may establish a relationship of care with a clinician other than the one assigned by the health plan. By following up with patients when they come in for a visit or via phone prior to a visit, front office staff may guide patients in how to change their assignment in the health plan records if the health plan requires a call from the patient. What happens when we discover that our panel size is too large? If the panel size is too large, meaning if we have more patients in panel to us than we have capacity to take care of, it's difficult to provide timely access, and patient experience and quality of care may suffer if we don't have time to address the needs of our patients. So what do we do when the anticipated demand for visits exceeds our supply? The first step that most practices take is to close the panel of that clinician to new patients. Templates and appointment scheduling workflows can be adjusted such that over-empaneled clinicians only have follow-up patient visits and are not scheduled for new patient visits. For under-empaneled patients, clinic templates should include new patient appointments to create supply to expand panel sizes to target. One practice, for example, monitors provider panel sizes quarterly and adjusts open clinic templates accordingly. Closing a panel can prevent a shortage of supply from becoming more extreme. However, without further action, it will take time for panels to level. There are several tactics to more actively level panels while supporting the important relationships between patients and their clinicians. In a multi-provider practice, under-empaneled clinicians can be encouraged to invite patients from their over-empaneled colleagues to switch clinicians. Similarly, over-empaneled clinicians can scan their lists each day to identify patients who can easily be moved and to introduce them to newer clinicians. This kind of warm handoff helps patients feel cared for and known through the transition. It works particularly well when there is a new clinician coming on board. Note that in both these strategies, it is important to involve clinicians in the process. Some practices use an administrative process to reassign patients on a larger scale. They may, for example, reassign patients who have been seen by another clinician or reassign relatively new patients. It is best practice to ask the original clinician to review the new assignments as they may have insight into the needs and best match for their patient. Similarly, it is vital to communicate the new assignment to patients, either in person or via letters, and to provide them an opportunity to switch their assigned clinician if desired. Reassigning patients with complex care needs requires additional preparation. Warm handoffs are critical in establishing the new patient-clinician partnership. It's important to have the previously assigned provider review their panel to identify the patients that are particularly high risk. This can be accomplished through a process like the following. The original clinician should summarize the care plan and active issues to be followed up upon transfer. The original clinician should also be involved in identifying another clinician who would be a good fit for their patient. Schedule a transfer visit at a time when the original clinician can introduce the patient to the inheritor clinician in a warm handoff. Involve the empanelment manager to outreach and make appointments at a given interval, such as 3 to 6 months after panel transfer, and to track patients who are lost to follow-up. A practice with only one clinician can also experience over-empanelment. While they cannot hand off patients within their practice, some of these same principles may apply to deliberate transfers of patients to other practices. Solo practices also have a need to regularly clean panels, because accurate panels are still the basis for effective population management and accurate quality metrics. Once we have an up-to-date panel in place, we can begin to stratify the various needs of the patients in our panel and answer questions such as, which of my patients are due for cancer screenings? Who among our diabetic patients might need more support to effectively manage their blood sugar? Which of my patients should be on daily aspirin? Which of them are currently taking it? Which of our patients are we most concerned about, and how can we best coordinate their care? Let's explore this pyramid and identify the unique considerations in each tier. Caring for the general population, those depicted at the base of the pyramid, may primarily involve the provision of prompt advice, including urgent care advice and systematized ways for delivering preventive care such as phone access, patient portal access, and same-day access to manage acute care needs for self-limited problems. Having this stratification process in place can help reduce the burden on clinicians of having to worry about who's overdue for preventive care needs, such as mammograms or colon cancer screenings. Using a team-based care Block 4 approach, people like medical assistants, health workers, or reception staff play an important role in the panel stratification and management process. Prospective panel managers can learn to review patient panels, to identify care gaps, and to talk with patients about getting up to date on their care. By training and empowering prospective panel managers to conduct the necessary outreach work to identify which patients are overdue for care, clinicians are free to focus on the people in the pyramid with more complex needs, requiring more sophisticated clinician decision-making, diagnostic skills, and ongoing care management. As we move up to the chronic diseases tier, we reach a population of patients who may benefit from health coaches. Through collaborative goal setting and self-management support, health coaches can work with patients with chronic diseases such as diabetes to provide the skills, resources, and confidence that enable patients to be active, informed partners in their care. At the top of the pyramid, we have patients with more complex needs, including multiple or severe chronic illnesses and behavioral health comorbidities such as depression and anxiety. People at the tip of the pyramid are not numerous, but can generate up to 40 to 50% of the overall healthcare costs for a population in a given year. Caring for this stratum requires interdisciplinary teams that may include pharmacists, nurses, social workers, and care managers, along with linkage to community-based resources. The stratification process we've outlined allows us to be more proactive about organizing our team and its resources. For example, a practice within an IPA network may coordinate with the IPA to provide care management services to its patients with complex care needs. Medical assistants can be assigned to do tasks such as calling patients who have not been seen within a given period of time, or those who appear to be out of date on preventive care. As another example, diabetic patients might be invited to a group visit facilitated by a nurse. As we've seen through the panel stratification process, a robust empanelment framework can help power higher level practice transformation initiatives. To sustain such a framework, it is important to continuously monitor and update our panel list of patients and to implement workflows at the practice level to help facilitate this maintenance process.